hospitals in and around Guwahati. So with these few words, something. Okay. With these few words, I'd like to call upon Dr. Mahamya Singh to start his deliberation.
Thank you, sir. Thank you for this, sir, for your kind words. First of all, I'll thank Pratiksha Academics and Counsellor and Anjana ma'am for having me today for this topic. Today, my presentation will be guidelines in the management of carcinoma thyroid. And mostly it will be on surgeon's perspective. So as we all know, carcinoma of thyroid is accompanies less than 1% of total body cancers. And it's also a commonest endocrine malignancies, and it has got a female predilection. So, and it commonly presents as a thyroid nodule, and incidence of thyroid nodule is around 4 to 7%, and out of this 4 to 7%, overall incidence of cancer is 5%.
We'll take that. This one is not working.
So, as a clinician perspective,
it's not working. But the other one I can find it.
Guruda, mute karo.
Should I continue?
Continue.
Yes. So in clinician perspective, our job is to for initial evaluation of a thyroid nodule, and then the treatment part, and followed by the post-operative risk categorization, and then the long-term follow-up. These are the 4 areas of interest where a clinician per se has to be dealing with. So the initial evaluation, after a thorough proper history and examination, when in history you have to take we have to take on to the family history, and then any history of radiation exposures. These 2 things are the main. Age is one of the most important criteria, as we all know, in risk stratification. And then in the examinations, we have to see the size of the thyroid, the mobility, and if there is any tracheal deviation. Along with this, along with the thyroid nodules, we also have to look for the cervical lymphadenopathy, if any. And after this examination, we need to do a voice and laryngeal examination so as to look at the recurrent laryngeal nerve. So these are the basic tests which we should do, and do the examination so that we can come to a more towards whether it's a benign or a malignant sort of a disease, which we can tell about from the clinical examination. Once the clinical examination is done, then we have to come to the investigations. And the 3 most important investigations that we need to do are the thyroid function test, ultrasound of the neck, and FNAC of the thyroid nodule or associated lymph node. Then we can do the FNAC of that lymph node also. In the thyroid function test, the most important point is that if the TSH is very high and the euthyroid status, then it's come to our domain so as to investigate it. But if the TSH is very low, then maybe a grave disease or any other thyroid nodule that has been there. So we need to send it to our endocrinology fellow so as to correct the TSH level. And once that is done, then we can evaluate further. But if the thyroid is euthyroid status or TSH is more, then we need to evaluate with an ultrasound neck. So in ultrasound neck, there are various scoring systems which will tell us whether the nodule is a malignant or a benign disease. Mayo Clinic thyroid ultrasound chart is there, TIRADS is there, Union 1 to 5 classification is there, and ATA classification is there. But out of all these 4, the TIRADS has been extensively used and is used in as the most common a scoring system which has been used worldwide. So as we all know, thyroids 1 is the normal thyroid gland where there are no nodules, everything is normal. Thyroids 2 where there is a benign lesion. Thyroids 3 probably a benign lesions. Thyroids 4 is a suspicious lesion, again where they have been classified into 4A, 4B, 4C based on increasing risk of malignant features. And thyroids 5 and 6, 5 is the probably malignant lesion, and thyroid 6 has the biopsy proven malignancy, that is an FNAC proven malignancy. And this has been incorporated in our system mainly by this Fernandez Sanchez article, the thyroid's classification of thyroid nodules based on a score modified according to ultrasound criteria. And this had concluded as this thyroid's classification based on score and to the number of suspicious criteria defined for malignancy may be applied in our daily practice. So if you all see again, then BTA guidelines in British Thyroid Association guidelines in 2007, that initial thing they had mentioned a point that ultrasound is rarely of use in assessment of thyroid nodules, but it may help guide FNA. But when the revised BTA guidelines came in 2014, so they gave a separate chapter on thyroid nodule ultrasonography. So there was a separate chapter only on ultrasonography, and they have rationalized the thyroid ultrasonography and USG guided FNAC based on the scoring system. They have also said that the ultrasonographic base follow-up should also be sent, that follow-up based on ultrasonographic appearances. So with this, the sonographic, based on the sonographic patterns, the American Thyroid Association, they also had risk stratified into high suspicious cases, intermediate suspicion, low suspicion, very low suspicion, and benign. So into the high suspicion cases, the ultrasonographic features which are coming are microcalcification, irregular margins, taller than white shape, rim calcification with small extensive soft tissue component, extrathyroidal extension. All these features on ultrasonographic and the most solid and hypoechoic nodule, these are the categories which fall under high suspicion. In intermediate suspicion, there is solid hypoechoic nodule with smooth margins without other suspicious features. In low suspicion, isoechoic or hypoechoic solid nodule with eccentric solid areas without other suspicious features. Very low suspicion is spongiform or partially cystic nodules, and benign is the purely cystic nodules. So based on these ultrasonographic features, ATA, American Thyroid Association, had also risk stratified it. So according to this risk stratification, if in high suspicion cases it comes, the risk of malignancy is around 70 to 90%. But ATA had also said that this because of the presence of only this high suspicion characteristics, we need not do an FNA unless and until the size is more than 1 centimeter. If a sub-centimetric nodule is there, we can, if it's high suspicious also, we can always observe that thing. We need not do an FNA just to prove it and then to go ahead with further treatment. So if the size is also more than 1 centimeter and in high there is 7, then only we should do an FNA. In intermediate group also, if the size is more than 1 centimeter, then only we should do the FNA. And in intermediate groups, the risk of malignancy is only 10 to 20%. As we come down low and very low suspicion, they have increased the size of the nodule. If it's a low risk group, then more than 1.5 centimeter. In a very low, then more than 1. In a benign lesion, they have not never said to do an FNA unless and until the features have changed over a period of time with repeated ultrasonographic changes. And the risk of malignancy has also come down to less than 1% in benign, very low in 3%. So after the ultrasonographic features, we have already come to our mind that these are the various features which looks like it will be a benign thing or a malignant thing. So we can have a fair idea about in our mind. And based on these criteria and ATA guidelines, we can follow the next, whether it's a nodule which is more than 1 centimeter and highly suspicion, we ask for a FNAC of that nodule. So this FNAC of this nodule is, there are various reporting systems. Bethesda and Thai classification is mainly followed by British Thyroid Association, and the Bethesda system, which is being followed all over worldwide most of the time. And it's ATA also follows the Bethesda system of reporting. So Bethesda, and if you see into the Bethesda system of reporting and the British Thyroid Thai system of reporting, both are almost same. Thus the nomenclature has been changed. Non-diagnostic on unsatisfactory, non-diagnostic, benign is non-neoplastic, atypia of undetermined significance or follicular disease of type 3, follicular neoplasm or suspicious for follicular neoplasm type 4, and suspicious of malignancy is type 5, and same thing is with British Thyroid Association also. Just the nomenclatures are changes. So even if the diagnosis is like unsatisfactory, but there is a risk of 1 to 4% of that this diagnostic have. So Bethesda system of classification, they itself says that you should repeat an FNAC. If it's a benign, there is a 0 to 3%. If atypia or flush is there, then 5 to 15%. Follicular neoplasm has 15 to 30% of chance of risk of malignancy. Suspicious for malignancy has 60 to 75, and malignant disease has 97 to 99%. So once we have got that FNAC also done based on Bethesda system of reporting, we came to know that this is either a malignant lesion. So if it falls under indeterminate, which is mainly your the follicular neoplasm, atypia of unknown origin, these two criteria categories mainly falls under your indeterminate group. And in this indeterminate group, if we have the resources, things, so we can do for a preoperative molecular markers to into these groups. And mainly the 7 gene panel is done: BRAF, HRAS, NRAS, KRAS, RET PTC, and PAX and PPAR. We can also do 167 galactin expression, and this is galactin 3 immunohistochemistry. If the RAS is positive, there is a chance of 84% of malignancy. Along with, if we have a as we do a 7 gene panel, so BRAF and RET PTC associated with PAX or PPAR positive, then the risk of malignancy increases to 95%. So in the management flow up, we have come to a suspected thyroid cancer, which has got a TSH normal or an elevated TSH. Then we did an ultrasonography of the nodule. We get an malignant features, so highly suspicious of this. Based on ATA risk guidelines, we did an FNA, we got a reporting system. Now that comes to the treatment. So management based on the cytology and ultrasound. If it's a non-diagnostic, and then we should go repeat FNA with USG guided. If it's a benign, then follow up. If atypia, we can do. If follicular neoplasm, either we go for a hemithyroidectomy or total thyroidectomy. If suspicious for malignancy, same thing, hemithyroidectomy and malignancy, depending on the various features. So based on these criteria, if the solitary nodule is less than 1 centimeter, hemithyroidectomy is sufficient. If the solitary nodule is 1 to 4 centimeter, then is again hemithyroidectomy and total thyroidectomy. Here, I like to mention that the ATA lesson guidelines have increased the size criteria up to 4 centimeter. The earlier in 2009 ATA guidelines had said if anything more than 1 centimeter nodule should undergo total thyroidectomy. But after a long-term follow-up, again in 2015, they have come up with that the hemithyroidectomy can be safely done in any nodule less than 4 centimeter in size, if no other adverse features or the highly suspicious features are present into the nodule size. Any nodule size which has more than 4 centimeter or are multicentric or bilateral, so they should undergo a total thyroidectomy. And any size of nodule along with a N1 disease, N1 that is central compartment, the nodal metastasis for there, then we should always go for a total thyroidectomy with a central compartment neck dissection. If any disease, any nodule with N1B or that is a lateral neck dissection, we should always go for a total thyroidectomy and a central compartment clearance along with selective neck dissection level 2 to 5, unilateral or bilateral based on the nodal metastasis. So as we all know that we have to do a central compartment clearance if there is a central compartment disease, that is the therapeutic central neck node dissection is mandatory. And if we have a lateral neck dissection, then as central compartment is the first echelon node for the thyroid malignancies, so we should uh, always do a central compartment disease. But if there is no nodes in the central or the lateral neck disease, then we they have considered prophylactic central compartment neck dissection in locally advanced T3 and T4 tumors if there is a aggressive histologic type subtypes like the tall columnar cell types or the oncocytic types, and there is gross extrathyroidal extension. And in intermediate and high risk patient, the data is still lacking, but some papers say that we should go for a central neck, the prophylactic central compartment clearance. So, but still what we follow that if there are any risk factors, most of the time we should at least explore the central compartment just to look for any nodes. If there are nodes, then we do a complete removal of the central compartment. So once we have done the surgeries, and there is a post-operative risk assessment, and that is based on the histologic features. So based on that histologic features, now we have got all the histology types. So based on that, we can go for the risk stratification of this patient. And this risk stratification will help us to go for adjuvant treatment, whether required or not required. So in the ATA low risk category, any papillary thyroid cancer with a no or local distant metastasis, all microscopic tumor has been resected. There has been no tumor invasion of locoregional tissues or structures. Tumor does not have aggressive histology like tall, columnar, hobnail types, or there is no radioiodine avid foci outside thyroid, no vascular invasion. And clinically N0, or if any nodal metastasis is there that is less than 5 micromillimeter, or nodal metastasis. So mainly, or an intrathyroidal encapsulate follicular variant of PTC is also there. Intrathyroid papillary microcarcinoma, unifocal or multifocal, including VRAF mutations. This all falls under low risk category, and we don't require adjuvant radioiodine therapy for this low risk group. ATA intermediate risk has got if there is a microscopic tumor invasion into the perithyroidal soft tissue, or there are radioiodine avid metastatic foci in the first post-treatment scan, if it's a aggressive histology, and papillary CA with having a vascular invasion, clinically N1 on pathologically N1 with all nodes less than 3 centimeter in largest dimension. So these are the criteria based on which we the ATA has put it into the intermediate risk. And at high risk, there is always a macroscopic invasion of tumor into the perithyroidal soft tissue, that is gross extrathyroidal extension is there. There is an incomplete tumor resection. We have left behind a thyroid tumor along the entry point of the recurrent laryngeal nerve, or sometimes we find that the recurrent laryngeal nerve is embedded into the tumor, and we try to preserve the recurrent laryngeal nerve, and a cuff of thyroid malignant thyroid tissue may be left over that nerve. So when there is a distant metastasis, and also there are post-operative thyroglobulin status suggestive of distant metastasis is there, and pathologically N1 any metastatic lymph node more than 3 centimeter large. This all falls under a ATA high risk group. So all these ATA high risk group, the ATA high risk group and your intermediate group risk groups warrants an adjuvant treatment. And adjuvant treatment are mainly in the form of radioiodine therapy, that is radioiodine ablation, and the levothyroxine therapy, which is the suppressive dose to suppress the thyroid stimulation. In the radiotherapy that I've already told that not necessary for low risk, but strongly recommended for high risk patients, mainly by the ATA guidelines. So in radioiodine therapy, we all know that thyrotropin stimulation by levothyroxine withdrawal, which is the gold standard, and TSS level prior to post-surgery, generally we wait for 3 to 4 weeks so as to TSS get raised more than 30. Once the TSS is more than 30, with radioiodine uptake will be more at a much lower dose, and we do it. And the other also methods can be used like recombinant thyroid TSH, that is the thyrogen, which reduces the treatment duration of the time, and is mainly because patients who are don't have much longer duration to stay, they cannot, because this TSH stimulation will lead to a lot of lethargy, malaise to the patient, so they have to go for work, and also people opt for this also, so that that can be done within 2 to 3 days post surgery, and everything gets over in a week time. So once the radioiodine therapy is done, then in external radiotherapy is required only for gross disease left, macroscopic gross residual disease that has been left into the thyroid bed, and also for residual or recurrent tumor that fails to concentrate radioiodine, that is the differentiated form of thyroid malignancies. So these two criteria mainly warrants external beam radiotherapy. So in the long-term follow-up, that is the ongoing risk stratification, we mainly do a clinical examination of the neck. So, and serum thyroglobulin and antithyroglobulin tests, neck ultrasonography, and radioiodine scan if needed. So the first in thyroid, the first follow-up generally after a complete treatment with the if radioiodine regulation is required or not. After the first initial treatment, we do the first follow-up at 6 months of time. At 6 months, we do this examination. In clinically, if that's all there are no nodes palpable, no nodules palpable, we just go for an ultrasound neck and serum thyroglobulin and antithyroglobulin level. If the serum thyroglobulin level is also no, antithyroglobulin antibody is also normal, and neck ultrasonography doesn't show any recurrent structural disease in the neck, then we generally don't go for a radioiodine scan. We ask the patient to again come after 6 months. After yearly, if it's a complete biochemical and structural good response, then after that, once a year, we do the testings. So in ongoing risk stratification to therapy, we can either get a patient with excellent response, which had both biochemical as well as structural disease free. If there is a biochemical incomplete response, like we do an ultrasonography, we did not find any nodules or nodes in the neck, but we found that the thyroglobulin level is very high. In thyroglobulin level, as because we also know that before the primary treatment completion, we had done a thyroglobulin level, which is our baseline level. So once we have that report that if the thyroglobulin is 1 and now it has gone more than 10, so then we have to evaluate whether why the thyroglobulin has increased. Then we can do a radioiodine scan. But suppose if the earlier thyroglobulin level was 8, 9, we have done an empirical radioiodine therapy also, and again on repeat after 6 months, the thyroglobulin level is again 8 or 9 only. Then there is not much increase in the thyroglobulin, so we can observe that patients also without having anything. But if the radioiodine thyroglobulin has increased, then we should go for a radioiodine scan just to evaluate whether there is any uptake in the thyroid bed or any nodule or nodes has come up. So this is the biochemical incomplete response. That is also said tennis, where thyroglobulin level is elevated, but there is negative iodine scan. Okay. Then comes the structurally incomplete response. So if there is, you see that at ultrasound, you find a uptake, you find a isoechoic or a echoic nodule or a hypoechoic nodule or any heteroechoic structural disease at the thyroid bed. But your thyroglobulin level is within the normal limits, that is less than 0.1. So once that is less than 1, we can easily observe as there is that nodule itself doesn't warrant further investigations. But if at the same time the structural disease is there and also the thyroglobulin is elevated, then these are the group of patients which needs to be further investigation. And there are indeterminate response where we see that there are nodule also, but the thyroglobulin is 1 to 10 in between. So we can observe this patient for a later date, and then observation becomes a little stringent. We ask for them to come at 3 months and repeat the test. If the tests are same again and it has not changed much, then we can keep under observation. But if there are changes, so based on the changes, we can take the further call. So similarly, like, yeah, and if an ultrasound next shows a suspicious features, so more than 7 millimeters strict hyperechoic punctuation, peripheral vascularization are there. So you have to see that this round shape, hypoechoic appearance or loss of hyperechoic hilum of them just do not justify an FNA of the nodule. It's the size criteria that has come by given by the ATA guideline that any lymph node that is more than 8 to 10 millimeter in size, and that 8 to 10 millimeter size, and there are suspicious features. Along with that, the thyroglobulin level is also high, then only it will advocate for an FNAC. But if the lymph nodes is less than 8 millimeter or 10 millimeter size, thyroglobulin level is very low or undetectable, then we can monitor with a serial ultrasound of that. Same as non-suspicious and less than 8 millimeter, monitor with neck with ultrasonography. Moderately suspicious, like thyroglobulin concentration is between 1 to 10 nanogram, and and the thyroglobulin last time is also was same, then we can always say. Highly suspicious is if there is thyroglobulin concentration is more than 10, then we have to evaluate further. Yeah, but it should always be compared with your previous thyroglobulin level. So once the thyroglobulin level, in follow-up, we got the thyroglobulin level, and we found that there is a structural complete response, but thyroglobulin level is elevated, that is the tennis symptom. Then in these cases, we do a radioiodine scan, but the radioiodine scan is not showing any uptake, but there are very high thyroglobulin level, like it is in the 800, more than hundreds, then we should always go for an FDG PET CT scan, because maybe this differentiated thyroid cancers have de-differentiated and will now get an uptake of FDG, which is also known as the flip-flop mechanism of the thyroid tumors. If there is any thyroid nodules or thyroid nodes which needs to be further evaluated, CT and MRI can also be done for anatomical delineation. So structural incomplete response. So we have a nodule, we have got a node. So we should always locate that node, and we should, if feasible structure, do a surgery and remove that node, nodal dissection if that area has been virgin area. But if it has already been dissected and there are just some nodes, and you can just remove that node and a cup of tissue around it, so that will be sufficient. And again, that after that elevation, we do after 3 months time, again do a thyroglobulin level, whether it has come down, and based on that further radioiodine ablation. In metastatic disease, we also, if it's a potentially curable disease, we do the surgery for the primary and nodal metastasis, and then treat the distant metastasis with a radioiodine ablation. If it's a non-curable disease, already metastatic disease, and also the local disease has been infiltrated into the trachea, then a systemic therapy may be useful, or TSS suppressive therapy can be done if there are other comorbidities, like elderly patients and patients who are not able to undergo surgery. Now comes the medullary carcinoma of the thyroid. So in the medullary carcinoma, the workup are almost the same, except for we need to do an serum calcium and serum calcitonin at the initial period once the FNA suggests that it's a medullary carcinoma thyroid. The calcitonin level will be always be high, and also some calcium level will be raised. Again, in that point of time, we need to do the catecholamine SSOS to rule out any MEN syndrome, and also the red proto-oncogene analysis has been done to the other family members, so as to go for a prophylactic thyroidectomy if any high suspicious characters are there in the, if red proto-oncogenes are positive in all the family members. And after metastatic workup, where management strategy is generally if it's a T1, T2 disease with intrathyroidal disease, total thyroidectomy with without any lateral or central one, so central compartment neck dissection is sufficient. But if it's a T3, T4 disease, then we should always go minimum surgery is the total thyroidectomy with central compartment clearance with a bilateral neck dissection level 2 to 4. So in these patients, prophylactic surgery based on moderate and high risk status that based on red photo-oncogene, that can also be done. And the patient needs to be follow up regularly. If there are gross disease left behind at the during thyroidectomy tumor resection, then this patient may also undergo external beam radiotherapy. In anaplastic thyroid cancer, we also know that just to assess if there are a small group of patients who may be benefited from surgical resection, most of these patients are very aggressive and they don't come at the initial stages. Most of the time, the stages are stage 3, 4. If we can come up with a small nodule size, and then chances may be there that you can have some cure in this group of patients. So with this, thank you. Ahmed sir, to you.
Thank you very much. You can, what do you call it?
Slideshow.
Up share.
Yeah, slideshow off. Yeah, slide share. Yeah, thank you very much, Dr. Mahamya, for your, broad outline of the management of thyroid cancers. Now, since we have time, we can take questions now from the house. If there are questions, please pass them on. Oh yes, I can see.
Yeah, a lot of questions are there.
there.
So first is from Hemanta Deka. How to manage papillary carcinoma, lymph node metastasis without palpable thyroid nodule? So in the diagnosis of a metastatic papillary, any thyroid tissue that is found outside of thyroid tissue, even if you have a, we have found a patient who had a jaw tumor, FNAC was micropapillary carcinoma thyroid from thyroid. So we did the segmental mandibulectomy and the final biopsy. Initially, it was something else. We did a segmental and the final biopsy was metastatic disease from thyroid cancer. So again, we did a ultrasonography of the neck. Thyroid was completely normal. There was not a even nodule, but as because any abnormal thyroid disease outside the thyroid gland is a diagnostic of metastatic disease. So we underwent to go ahead with a thyroidectomy, then do a radioiodine scan, and everything was okay. Then we had followed. So we need to do without the absence of any palpable thyroid nodule. If you have a node metastasis which is coming out to be papillary carcinoma, then we need to go for a ultrasonography of the neck. If ultrasonography of the neck shows any nodule, then the usual procedure of going for an FNAC based on the criteria. And if that no nodules are there, then also we have to do a total thyroidectomy with a central compartment clearance and a lateral neck dissection.
Does that answer your question, Hemanta Deka?
Hemanta, it's clear, or you want to ask anything, or you want to add on anything?
Mohammed, I have understood the answer.
Hmm.
Am I audible to you?
Hello?
Hello,
Yes.
Mohammed, am I audible to you?
Yes.
Yeah, I have understood the answer. My second question is how to manage, how to suspect papillary carcinoma in a thyroglossal cyst and how to manage it. Because once I did the operation thinking it to be branchial cyst, later on biopsy report, it came to be papillary carcinoma. So I had difficulty in the surgery because I did put the incision over the lateral neck, and I had to do the thyroidectomy. Then I had difficulty in identifying recurrent laryngeal and so how to suspect and how to manage papillary carcinoma in a thyroglosal cyst.
Suspicion is clinically if these are hard nodules, any hard nodules, sometimes you see thyroid, mainly these nodules are very hard. If you have this hard nodule feeling, then you should always suspect a malignancy. If they are cystic or sometimes it's a soft, then always most of the time we do thyroglossal cyst or any other thyroid nodule or any, we do a baseline ultrasonography and scan. So we need to do, if there are ultrasonographic features are again suspicious of any malignancy, then we can add. But if you come up post-operative like everything was normal, ultrasound thyroglosal cyst, you do an FNAC thyroglossal cyst came out, and once you do a thyroglossal cyst excision, either a cyst trunk compression or just an excision, you do a, and post-operatively it came out to be papillary carcinoma thyroid. Then because as already you have done an ultrasound and ultrasound had showed that this your thyroid gland is normal, you just have a thyroglossal cyst. So once you have removed the thyroglossal cyst, now the features of thyroid, as it's a complete removal of a thyroglossal cyst, you send it to for biopsy. Now the biopsy will tell us whether it's there are papillary carcinoma classic variant or any adverse histologic variants like columnar or tall cell. So based on that, if there is, if they say that there is extrathyroidal extension is there, the thyroid tissue has been exposed. So all these are other features that you have to take upon and then take your call finally. If the thyroglossal cyst is more than 3 centimeter size, so if it is more than 4 centimeter size, then anyway it warrants a total thyroidectomy. So you have to go to a redo your surgery, go for a total thyroidectomy.
Dr. Hemanta Deka, I think your question or your case was a mass in the lateral neck, or was it midline?
It was a lateral neck mass, sir. And in ultrasonography, they gave a clue that it was a solid cystic mass. It was not purely cystic mass. I thought it to be a branchial cyst, and I planned for a cyst removal under GA, but I had difficulty in the surgery because the mass was adhered to the surrounding structure, and it was attached with the lateral lobe of the thyroid.
So similar patient had also come. I think counsel must be knowing that in 2000. Yeah, he was. He was operated in 2014 only with diagnosis of a branchial cyst. It came out to be papillary CA thyroid. He was contacted, but he never returned. So he came in 2014 with a thyroid malignancy. Okay, 2000. It was operated in 2014. He came in 2022 with a thyroid malignancy, huge nodes. So we operated and now did a total thyroidectomy along with central compartment on lateral side neck dissection. Neck dissection was also done. So it happens. But just the thing that if it's is adherent to the upper lobe of the thyroid or anything, then we should have a thing in our mind.
Hello. One interesting observation I'd like to make here. We had published a paper on 2 cases of thyroglossal cyst carcinoma. In one case, we had done a total thyroidectomy. In one, we did only an excision. We had done an excision of the thyroglossal duct, and we did a cyst trunk basically. Now, none of the cases recurred. When we published this paper, actually we put up that query that what Hemanta is also asking something similar to that what would be the ideal treatment when you have a PTC confined to the cyst, whether you go, because when we took out we did a total thyroidectomy, the specimen of the total thyroid specimen was negative for malignancy. The disease was only in the thyroglossal cyst. And both of these cases that we did were presented with the cyst quite late in life, around 60 years of age. So probably whenever you have a person presenting with a thyroglossal cyst quite late in life, we should think about malignancy and with a proper FNAC done as well.
Hello. Hello.
Yeah.
Can you hear me?
Oh, yes, Rajati, yes.
Anything to add?
Hello.
Yeah, the point in question is that he has already said that it's a mixed cystic solid lesion. Now, when you get a mixed solid cystic lesion, always FNAC should be targeting the solid part of the solid component of the cyst,
Yes.
rather than going into the cyst. So if you do a FNAC of the solid component of the cyst, it is very easy to get a papillary carcinoma or whatever it is preoperatively. And secondly, the incidence of carcinoma in a thyroglossal cyst is very rare. But by doing a good ultrasonographic examination and taking a FNAC from the solid cystic, solid part of the solid cystic lesion, will most of the time will give us a definite diagnosis preoperatively. And once we diagnose this carcinoma in a cyst, I think we should go for total thyroid, because most of these patients will require ablation therapy, because it is taken anything that is outside the thyroid bed is taken to be a metastatic disease. So it will help us to follow up this patient by doing an iodine scan. He might be having some microscopic metastasis elsewhere, either locally or distance also. So at least we should go for a total thyroid accordingly.
Yes, I think that is the thing, because these lateral neck, masses which harbor thyroid tissue was earlier known as lateral aberrant thyroid, but now it is thought that these are actually metastatic disease from the thyroid itself. So as Dr. Rajati has said, these should be treated as metastatic disease. And if there is any, I'll reiterate what he said, that if there is any solid component in a cystic lesion in the lateral neck, the FNAC should always be done. And we must, if there is any doubt still, this ultrasound may be reviewed by somebody else if you want some other ultrasound. And the FNAC also should be reviewed if there is any doubt in your mind. Because this, you said the mass was hard or firm to hard, isn't it? Hemantodeka, your case.
Most
Hello?
of the time, it is very helpful, the ultrasonologist, if we do it very accurately, most of the time we will get a good result.
Yes. Because you need to a really good sonography to be done in the neck to come up with, positive diagnosis in these cases.
Lateral neck, always go for a total thyroidectomy and then do. But in thyroglossal cyst, it depends upon the size of the cyst also, because when it is more than 4 centimeter, anyway you require any nodule of more than 4 centimeter size or 3 centimeter size, you need to go for a total thyroidectomy. But if the cyst is 1 centimeter, young boy, 12 years, so you can always observe, because you have already done an ultrasound, and ultrasound doesn't show anything. So explaining to the patients, we can always observe these patients, because in a young child of 12 years, 13 years, where this thyroglossal cyst mostly present, so you no need, we should not be in a hurry to go for a total thyroidectomy for this young group of patients whose development depends a lot on these hormones and all.
When the medullary carcinoma also presents with metastatic only neck node without a lesion in the thyroid.
Yes, Rajda.
Recently, 5 days back, I have operated the patient. Patient presented with only a 4 centimeter neck node in the supraclavicular fossa left side. Biopsy came out to be metastatic thyroid carcinoma, medullary query. So you can have this type of presentation.
You did the calcitonin, Dada?
Yeah, we did the calcitonin. Calcitonin was high. It's around 600, something like that. So accordingly, preoperatively, we have done a calcitonin also. And accordingly, we have proceeded for the total thyroid and neck dissection and all.
Yes. Okay, thank you, everybody, Dr. Hemantodeka and all the rest who have taken part in this discussion. Because we are going to finish our allotted time. We can
Sir,
go on to the next question. If there is
sir,
no other observation from
Fukan
Sir,
sir has said TSH. Yes, Anjana ma'am.
Dr. Biplab now has raised the
Yeah.
hand. Long
Yeah,
time.
Good evening.
okay.
Good evening, everyone. Nice discussion and nice presentation by Dr. Uh, which one?
Mahamya, yes. Yes, Biplabda.
Biplab, your
Mahamya.
Yes.
And voice, sir.
yes,
Am I
we can
audible,
hear.
sir?
Yes.
Yes.
Okay. So 20 years, history is 1.5 months, and large nodule on the right side, multi-nodule. And FNC was just not conclusive anything, and done in a good center. And USG also like solid nodular mass, no increased vascularity, no irregularity, no calcification. Those things are expressed. So what is like should be the policy like in those patients?
Large nodules, you have seen multinodular goiter.
Multinodular, not goiter, not cystic.
Yeah,
It is a farm and
any multinodular thyroid swelling with large cystic swellings or large mixed type of swelling always warrants a total thyroidectomy.
total thyroidectomy. Well, that is what like so we should go for total thyroidectomy.
You should go for a total
Right.
thyroidectomy.
Now, what was the age of the patient?
So it is about 20 years. She is 20 years old.
20 years. And the disease was in both sides or one side?
Now it is mostly on the right side, but centrally also maybe over the isthmus also she is having. On the left side, they have said left side is normal. Left side is normal as per sonography. The size is normal, and then the texture is also normal. So like I was thinking whether it could be like a lymphoma kind of thing also you should roll out in this patient. So I have gone for more detailed checkup like USG of abdomen and all those things I'm going at this moment, like chest and everything I'm seeing. So if I have to go for excision, I should go for total or I should go for hemi in this case, in such a case.
Looking into the opposite lobe,
FNSC is
looking into the
sir,
opposite lobe is completely normal. Still, you can go for a diagnostic
normal, not
hysterectomy.
Yes.
But you have to counsel the
hemithyroidectomy.
it comes out to be malignancy.
Yes, she
it
might.
becomes a multifocal disease.
Yes, she
Then you should counsel the
compression.
patient
She
to come as a malignancy
Yes,
in the final histology. Then you should can proceed for the total. But as
Yes,
of now, looking into the opposite lobe is normal in your ultrasound. That is also
Yes,
done
yes.
by good sonologists. Still, you can go
Yes,
for
yes.
lobo-isthmusectomy. You can remove the whole lobe. You can remove the whole of the isthmus, but you can leave
Mhm.
behind the opposite lobe. But you need to
Yes,
counsel the patient. If it becomes malignancy in the final histology,
might
then
need
you
require.
May require a completion thyroidectomy. Yeah.
Thank you so much. Thank you, sir. Thank you.
Can we go to the next question then?
Next question, Fukan
Next
sir.
question, Satyabrata Fukon.
TSH is low.
Yes.
Any advantage of doing iodine scan?
Whether it be iodine scan or other this thing also, technetium scan, any take on
Yes,
that?
sir. The thing is that if the TSH is very low, if it's not more than 30, the sodium iodide importers are the cells, the TSH cells are not hungry. So you have to give to make an uptake also, you have to give a higher dose of radioiodine. So
No, I
once
think Mahamya, the question is from Satyabrata Fukon. Is it a preoperative low TSH or
Not
postoperative?
post-op.
not possible. Okay.
Preoperative.
That's starting your investigation.
Okay. So
Yes.
Mahamya.
Yes, sir. TSH is low, and then yes, you can do this. Not done nowadays, but earlier it was done to see the cold nodule and the hot nodule things when there are Graves' disease, high TSH and all. So now, but as because the ultrasound and everything is there, they give that how size of nodules, whether it's suspicious, non-suspicious, and they generally do a treatment based on other features of Graves' disease. The endocrinologists do the treatment part first, and if that is intractable Graves' disease, there only they go for radioiodine scan and all these things. But initially, earlier it was being done. Rajda, Amit sir,
Once the medical
Some-
treatment is in a Graves' disease, then we can go for a iodine ablation in a Graves' disease.
yes.
But iodine ablation is not the first line of treatment in a Graves' disease.
No,
So
sir
what-
is asking about scan, not ablation, scan. Should we do a scan if TSH is low?
Mostly in the literature part now, but practically it's very rarely done.
Correct.
Amit sir, কিবা add করিব?
If there is an obvious nodule, some people would like to know whether there is any cold nodule there or a hot nodule, which is, isolated hot nodule, which might be an autonomous nodule. Because they're the endocrinologist, they want to know whether it's an autonomous nodule or not.
Most of the time it came up to be Hashimoto thyroiditis.
So there, ultimately you have to do an ultrasound and an FNSA, maybe. If it, Mahamya, what do you have to say?
Sir, same thing only what you told only, that nowadays the initially ultrasound is sufficient enough, then do the medical management, and if for academic and I want to see, then we can do it. Earlier it was being done, now it's not done that unless for radio iodine ablation only, if they want to do. So next,
Okay, is there any other this thing observation on this question? Dr. Fukon?
No, that's why I'm asking about this, because I've seen 1 or 2 cases, this THS low, very low. If we get the case by the nuclear medicine people, and it is suspicion of Graves' disease, they go for ablation. One of my colleagues, who has been diagnosed like that, and he has been ablated in Delhi, AIMS. And now he is recovered almost. Therefore, I'm asking, not to the line of the cancer, to the carcinoma.
yes sir.
No, here I think there are two options. One is radioiodine ablation, the other is antithyroid drug still.
Yes, but no, antithyroid drug is not responded. Then therefore,
sir, that's
they
what.
gone for ablation.
Kind of
Okay.
treatment is based the antithyroid drugs, medical
Even the
treatment.
PTU also, after carbaminomarcazole, PTU also not responding.
Yeah.
In that case, of course, you have to go for ablation.
Okay, thank you. Go for next one. Otherwise, the time will be less.
Sir, just like to add one point, even after ablation, you can go for surgery.
Yes.
Even
No.
before ablation also, we nowadays go for surgery.
You can get the gland fibrotic, so bleeding and all is less. In those cases, you can go for surgery also.
Yes, it's correct.
Provided it's euthyroid before surgery.
Go
Yeah,
for next
make the
but-
question.
patient
Many
euthyroid.
questions are there.
So next question, what will be the risk classification if FNSE shows Hurtle cell?
Hurtle cells, I think it's fall under high risk group only, sir.
Yeah, Hurtle cell is a high risk group.
High risk group only. This is where.
Even in final histology, if we get Hurtle cell carcinoma, we should treat it at advanced stage of the disease.
Yes. Chances
It's a high risk type of follicular carcinoma, isn't it?
yes, sir. Hurtle cell type of follicular carcinoma. Follicular carcinoma anyway have a not bad prognosis as compared to papillary CA thyroid cancer, and then Hurtle cell type, another with a follicular carcinoma, has again that increased risk. So I think it falls under the high risk group only.
Nitesh sir is raising his hand.
Nitesh, you're muted.
Sir,
Sir, good evening.
Good evening, Nitesh. Please come with your question. We're almost running out of time.
Hello, sir.
Yes.
Oh, sir, good evening. Sir, I just wanted to know before pre-operatively, what are the criteria that we should start looking for any metastasis in case of CA thyroid?
Pre-operatively, if you have
Yes, of course.
Preoperatively, the only thing is that first of all, clinical examination, we do only, we palpate the neck for the nodal metastasis. If there is no nodal metastasis, then we do all these things. Then ultrasound again proves that they also tells you about the local regional thing. So if ever is clear, then I don't think we do for anyway. We do for a GA case chest X-ray if there are any miliary mottlings and all. Then only we suspect other things. Otherwise, most of the time we do routine clinical examination and ultrasound. If there are no neck metastasis or anything, then we don't look for a distant metastasis anyway.
Can I add something, Mahamya?
Yes, Rajda, always.
In a case of FNSC where it shows poorly differentiated carcinoma or anaplastic carcinoma, then you should go for a metastatic workup.
Yes.
In a papillary and follicular, if it is not symptomatically, patient doesn't have any symptoms, then metastatic workup is not that much recommended.
I think that's
most of the time patient will complain of bone pain, spinal metastasis, one of the commonest metastasis. So in those cases, you should go, but aggressive histology like poorly differentiated carcinoma, then anaplastic carcinoma, the presentation itself, you should go for a metastatic workup.
The histology defines.
Yeah, histology defines the initial metastatic workups.
Thank you, sir. Thank you so much.
Yes, for differentiated carcinomas, as it is, you're going to do a thyroidectomy. So you don't need a metastatic workup. It is only in the unfavorable or aggressive histology types when you're suspecting. Yes, you're right. I think that's a good observation from Rajati Das. TSH generally raised by 4 weeks. RAI, yeah, there is a thing. Even after 30 days or 2 months, RAI what's that? Not raised. TSH is not raised. Then what will you do?
If TSH is not raised to 30 even after 2 months of this, then they are candidates for thyrogen injection, recombinant thyroxine. But because it's costly, so it's not done much over here. But outside they do it once that radioid TSH is not generally raised even after 2 months time. Because the thing is that it's not that cannot be done. It can be done if it's TSH is 15-20, but they have to give a higher dose. So once you give that higher dose, the remnant microscopic disease that are there, they get stunned. That is the stunning effect. They are oversaturated with it. Though when they show uptake, now if you go on for treatment of these patients have they have already have this stunning effect of the radioiodine high dose, not the actual therapeutic dose, but the high dose radioiodine. Generally, they do I think 2 to 3 millicurie for radioiodine scan. For a treatment shot, they give minimum 30 for empirical if there are mild uptake or something. Otherwise, 50 if there are gross uptake, high uptake is there. So if they have to increase the dose from 3 to 10, so this will give that stunning effect, and the therapeutic dose will not be working as they should work. So that's why they don't do this radioiodine scan unless and until the TSH are more than 30. But okay, we can always do a recombinant thyroxine thing, thyrogen injection.
If it is not available, then what you do?
So that's what I was telling. So, sir, not routinely used because of financial also. But the thing is that we can wait. If not, then we have to think that there is what you said,
residual
thyroid disease is there.
Yes, otherwise TSH should have come to 30.
Yes.
We have yet to see any case in which it has not reached 30 as yet. I don't know what is the experience of others.
Yes, so one of my patient had this, but he was more than he doesn't came more than 30, but it was like after 1 month 10 days or something, it was like something 27 28. So they did the radioiodine scan in that one.
Most of the time, if you do a total removal of the thyroid tissue, There should not be any reason that it will not increase.
Hmm.
And
Yes.
interestingly, in that scan also there was no uptake, mild residual bad uptake that we generally see. So that was the thing.
Thank you.
So again, TSH generally lays by 4 weeks. Radioiodine indicated according to risk stratification. Yes,
Hmm.
this is from Rajda only. Yes, generally it's more than 4. Most of the time when we see because of this lethargy, malaise, a lot of patients I have started saying that during 4 weeks time, the TSH goes more than 100, more than 150.
Yeah.
But we generally need more than 30. So I started doing the TSH at 3 weeks only, and most of them have around more than 30 only. So just increase by 7 days time, decrease
Mhm.
the duration. That's all.
Yes, yes. If the patient feels too unwell, you can
Unwell.
advance the
Even
radioiodine scan.
one of our patient, we had to do a tracheostomy because when we had stopped because we had left gross thyroidal because they had the nerve and he was an elderly patient, so we thought of giving radioiodine ablation. But the 3 weeks time only he had so stridor and all, so we thought what happened, and immediately in emergency tracheostomy was done. So we thought that we will do the radioiodine ablation on and everything. Later we started him on thyroxine. Once we did the thyroxine, started on thyroxine, he had that distress and everything gone. And then
Actually, patient with lot of comorbidities, no cardiac disease and
cardiac and all.
those cases we can do it the little bit early also.
Yes. So
Anjana, you finish up the questions, that questions. Some are
Yes,
there.
sir, Dr. Rupjiti and Dr. Satabdi. Dr. Mahamya, just see.
yeah, Surupjati, management of 6 centimeter thyroid nodule in one lobe with FNAC showing Bethesda 4 follicular neoplasm. Is it wise to go for hemi or total thyroidectomy? Rupjati, it's just the size only doesn't matter, but you have to explain that in follicular neoplasm there are 15 to 30% chance of malignant transformation. If it comes out to be malignant transformation, you go to completion thyroidectomy. If the patient agrees, go for a hemithyroidectomy and plan for a total thyroidectomy or a completion thyroidectomy later on. If the patient agrees, says that you do it one time, go for a total thyroidectomy. It's the patient decision mainly what we follow.
Of course, the implications must be explained to the patient if you decide for a total thyroidectomy upfront.
Yes.
Dr. Satabdi also has question.
The subcentimetric node in USG, does it require central compartment? Subcentimetric node in ultrasonography, does it? You haven't mentioned it. Is it in the central compartment? Central compartment, Satabdi. If it's in the central compartment, you have to look whether ultrasonographic features whether it's a suspicious node or not. If it's a suspicious node, subcentimetric around 8 to more than 8 millimeter, then you can do an FNA. If it is less than 5 millimeter, less than 8 millimeter or something, at the time of a total thyroidectomy, if you are planning for a total thyroidectomy, then you can just ipsilateral central compartment clearance, you can do it. If you are planning for a hemithyroidectomy for that patient with a subcentimetric nodule in the thyroid gland also, then you don't need to do it. You can always leave it. Mainly the central compartment neck dissection also depends upon their thyroid nodule status, based on which we take a call on the center whether to do a prophylactic central compartment clearance.
Yes, and a corollary to that, when you say a central compartment neck dissection, what does it encompass? Does it encompass all the 3 or 4 parts of the central compartment?
Sir, generally it includes from carotid to carotid, from above hyoid to the suprasternal notch, above the recurrent derangement, both side recurrent derangement nerve. All tissues, fibropathy along with the lymph nodal removed is the central compartment.
Nowadays, there is a classification of
Yes.
paratracheal, pretracheal, and prelaryngeal parts of the central compartment. What is your take on this?
Sir, if you most of the time when we do a central compartment, we are conservative. What else? Because of the parathyroid glands and the nerve, we don't worry much because nerve we already see it before while doing total thyroid. So nerve is not an issue, but mainly the parathyroids are an issue. So so while doing echo, I clearly identify the parathyroid tissue, kept it away, and then do the central compartment. So most of this time we are little conservative. But any gross nodal metastasis, we remove it completely along with the fibropathic tissues.
Because it's very difficult to know whether you have got other micrometastatic node or not. So it's better you remove all the fibropathic tissue in the whole compartment.
Because of the concerns regarding the parathyroid, there is a school of thought which says that on the side of the disease if it is a unilateral disease, you do a central compartment of that side and don't touch the other side, so that you can at least preserve that side inferior parathyroids.
Okay.
Inferior and superior both. So that is another way of looking at it, because the hypocalcemia can be more, infinitely more distressing than a vocal cord paralysis. So there's a school of thought that if it is an unilateral disease with no radiologically and clinically demonstrable at surgery nodes on the unaffected side, then it is better not to touch that side. Rajati, your comments, because you do a lot of thyroids these days, no?
No, our practice is that, sir, after identifying the vasculature of the parathyroids, once one level is positive, we always go for detection of all the levels, considering that there might be a micrometastasis in the other levels also, which are not detected by the ultrasound, because ultrasound, it's very difficult to locate the central compartment nodes preoperatively. So once detected, our policy is to clear all the levels, considering and securing the blood vessels, blood supply to the parathyroids as far as possible.
It's as far as possible is right, because there are people who will still err on the side of doing less than more.
Yes.
Niteshwar has his hand up.
No, the previous.
He has
Previous
asked.
hand.
Yeah.
Hand is
Previous
still up.
hand.
Yes. First he raised
That
his
is-
hand, then he wrote the question.
Sir, I
That is-
asked.
Okay.
Maradona then.
Oh, Maradana's hand of God. Okay.
I think our questions finished in the chat box.
Yeah. It finished.
Sir, I have a question. Actually, I have misplaced the ultrasound, one right-sided thyroid swelling. His FNSC report was like this: oncocytic lesion, Bethesda category 3, adenomatous nodule with oncocytic metaplasia. Now, how will proceed for the management?
Mahamya?
It's again that Bethesda type 3.
Yes.
So based on the thyroid nodule, again, you can say whether you can go for what is the size of the nodule?
That exactly, I forgot the actually ultrasound missing. So it was like.
Okay, no, ma'am. Anyway, we have to discuss along with the patient only, ma'am. This is the right? It is not malignant. Either you do a hemithyroidectomy. If something comes up, we go for a completion. If again if it turns out to be malignant, if we go for a completion. If it's benign, then well and good, nothing to do. You are well okay. If you have something comes up, then we have to do a completion. Sometimes patient opts for total thyroidectomy. Sometimes patient opts for hemithyroidectomy. That is completely on patient's choice.
This is what is called diagnostic lobectomy, no? once your diagnosis is not
That's why
confirmed in
indeterminate, they have given a diagnostic lobotomy.
opened up same site for diagnostic lobotomy.
Okay, thank you. I think this is end of the questions.
Madam.
Yes.
Just one more.
Yes. Please ask.
They're
Yes,
related
sir.
to thyroid. What is the real significance of even in nodule, colloid nodule also, colloid nodule with cystic degeneration? Real significance, I mean.
Colloid nodule with cystic degeneration. You want a chance risk of malignancy is less than 1% in this also.
And adenomatoid goiter.
Adenomatoid goiter, see, the thing is that the adenomatous nodule, that means the adenomatous goiter is an adenomatous nodule. If you say a goiter, then there might be cystic degeneration along with that nodule solid component. So anything that has again comes up with your adenomatous nodule is again your Bethesda 3. So same 10 to 20% chance of malignant transformation is always there. So you have to do a complete ultrasonography, because if FNA is only adenomatoid nodule, but ultrasonographic features shows a hypoechoic with a blurred margins, them taller than white. Few features are there which are more towards the malignant side. Then we can be sure that okay, it has come indeterminate, but because of ultrasonographic features, this might come to a CA. So both your ultrasonographic features as well as your FNAC reports both should come into your treatment decision making.
And see whether the patient is young or old.
Yes, that's other age is one of the most risk stratification criteria.
And male or female, that is another very important thing, because males are more leaning towards high risk.
Breast cancer.
Sir.
And now, of course, with the new guidelines, the age of the cutoff being 45 is now revised to 55. I think most of us know that now, by now. And the other thing which is coming in more reports is the NIFTP.
Yeah.
So we have to be aware of that. And to get a diagnosis of NIFTP, we have to have a very good histopathological report from the pathologist postoperatively to say that it is actually non-invasive follicular thyroid lesion. Yeah. Because these are now, classified as non-cancer. Because if you say cancer, then it has a different implication or connotation for the patient. So these are not classified as cancer nowadays. So if there is no other question, I think we can wind up and close this session with permission from the organizers. Dr. Anjana?
Yes, sir. Thank you, sir.
Thank you, ma'am. Thank you.
Yeah. On behalf of Protix Academic, I extend my heartfelt thanks to Dr. Kudus Ahmed, sir, for excellent moderation, sir. And I thank to Dr. Mahamya Singh also for excellent presentations, which made us very clear. And my also heartfelt thanks to Dr. S.B. Fukan, sir. Always he is there with us, always with us. And I extend thanks to Dr. Rajjyoti Das also for active participation. And all the viewers, Dr. Niteshwar Singh and all the viewers, thank you so much, and looking forward for another year to go ahead. Thank you. Good night.
Anjana, before you
so
end,
much, and
just
yes,
let me
happy
tell.
advance Christmas and Happy New Year, sir, ma'am, everybody.
Merry
Yes,
Christmas.
yes. And Anjana, before we end,
Yes.
the good, I mean, this celebration has been very good because you have participants from Manipur, from Tripura, from Nagaland. So you have had a very good representation in this meeting today.
33.
Lastly, I had actually skipped, but it's natural, everybody knows That technical know-how started with Dr. Biswajit Gogoi, but now I understand that Sanchita and Anjana can manage well, even without Biswajit Gogoi. They have also become experts.
No, sorry.
Congratulations to both of you.
He's there,
Yes.
he's there, sir. He's there, he's also pillar.
Yeah.
Biswajit is back.
Silently, he's sitting, sir.
Okay.
No, he has
Welcome
gone
back,
to level
Biswajit.
4. You are
Yes,
level
sir.
2.
We are just stepped into it a little bit. Thank you so much,
Thank you.
everybody. Thank you. Good night.
Good night, everyone.
Good night. Thank you very much. And welcome back, Biswajit. And congratulations.
Congratulations, Vishal.